Hello, welcome. My name is Victoria, and thank you for joining me in another study session as I prepare for my NCLEX. Today, I'll be talking about liver cirrhosis. I'll be going through it and studying liver cirrhosis. So, join me and kindly follow for more study sessions. So, liver cirrhosis is a chronic liver disease that destroys the structure and function of the liver lobules. So, in this condition, there is destruction. It's a chronic, progressive disease of the liver that is characterized by degeneration and destruction of hepatocytes. So the liver cells are being destroyed, they begin to degenerate, and they form fibrotic tissues that become ineffective in carrying out the main function of the liver. Liver performs so many functions, and this whole cirrhosis can lead to can lead to death. So we have different types of liver cirrhosis, okay? But it's important to know that sometimes this cirrhosis is irreversible, and then it is characterized by diffuse inflammation. So there is swelling of the hepatocytes, then there is fibrosis of these liver tissues that now causes scarring and obstruction of blood flow through the liver. We have three classifications of liver cirrhosis. There is the alcoholic type, alcoholic liver disease. It's also called Nclex cirrhosis or alcoholic cirrhosis. It's the most common type of liver cirrhosis. Then we have the biliary type and the post-necrotic type. All right. So what happens in all these problems? Just for an overview, we know that in alcohol liver disease, which is the most common type, the risk for this is related to people who consume high amounts of alcohol, the consumption rate, the number of years in which the client has been taking this alcohol, as well as the serum level of alcohol. Okay, what is the composition of alcohol in this person's blood? Should we just say blood in quote? So it may occur too, this liver cirrhosis may occur from chronic hepatitis B, hepatitis C, or toxic liver damage that comes from drugs. Like all these drugs like Tylenol, acetaminophen, yes, barbiturates, some sedatives, some hypnotics. They play a role in, they are metabolized by the liver, and then if the patient keeps taking this too often, it can lead to liver cirrhosis. Then we have the post-necrotic cirrhosis or chemical type. Also, heart failure, all these things, obstructed bile flow can even cause the biliary cirrhosis. You know, in our previous lecture, we talked about cholecystitis, where we say it's an inflammation of the gallbladder. And also, we know that the bile juice is going to pass from the cystic duct to the common bile to the common bile duct. And if there is an obstruction at the level of that common bile duct, there is going to be backflow of bile juice that will go into the liver. And because the liver is very sensitive, and also because the bile itself is a chemical irritant, it's going to cause damage to the liver tissue, and that is what also causes this biliary cirrhosis. It's part of the cause. So basically, we have said that in liver cirrhosis, the functional liver tissue is gradually destroyed, and then it is replaced with a fibrous scar tissue. It becomes replaced with a fibrous scar tissues. And then as these hepatocytes and liver lobules are getting destroyed, the metabolic function of the kidney is lost. The kidney is unable to do what it was made for, because its hepatocytes, the cells that would have helped it do its job with ease, they are being destroyed. So these scar tissues, these fibrotic tissues, they form constrictive bands within the liver lobules. Okay, they form constrictive bands within the liver lobules, and then they disrupt the flow. They disrupt blood and bile flow within the liver. So blood cannot flow within the liver adequately. And what would that cause? That would lead to portal hypertension. Just have it in mind. So when there is increased pressure in the portal venous system due to this impaired blood flow caused by the fibrotic and scarred liver tissue, we know that we have portal hypertension. So this is our first sign and symptom. If you're with your jotter, kindly jot it down: portal hypertension. All right, let me take my jotter. It's a study session. I'm also learning, and I'm trying to make the concept easy for everyone, for myself, for you listening to me, to get this concept. So please take your jotter and let's jot as we go along. Okay, all right. So we have the first sign of portal hypertension. I've taken mine down. Okay, let's continue. We also say that the obstructed bile outflow, right? That is in the cystic ducts, where we analyzed how the common bile duct can be obstructed by a gallstone, and then that will now lead to backing up of bile into the liver. So that obstructed bile outflow begins to damage the liver cells. So loss of functioning liver lobules ultimately leads to the failure of that liver. That's liver failure. Liver failure is another complication of this whole thing. So under the complication part, you can just write complications in another side of your notes, and then you put liver failure. All right, liver failure. If you want me to share my notes with you, I can take a snapshot of it and send. Just comment and I'll do that. Then in alcoholics, now, you know, we said alcoholics, they have this we have the alcoholic liver disease. That's the Nclex cirrhosis, and that's another name for it. So what happens is that there is increased serum alcohol level. The blood level of alcohol becomes so high, and then what happens is that there will be changes. It will cause metabolic changes in the liver, which will lead to fatty infiltration of hepatocytes. That is, now, alcohol metabolism will produce a toxin. As the alcohol is being broken down, a toxin will be produced. This toxin will now cause inflammatory response and swelling of the liver parenchyma, and then damage the hepatocytes. So that damaging of the liver cells will lead to accumulation of fat in the liver cells and the lobules. So if this person continues to take this alcohol, this is what will happen. Are we there? So this is that is what happens as the person continues to abuse the alcohol. Now in this early stage, where the metabolic process of metabolic breakdown of alcohol is causing this hepatic infiltrates, fatty infiltrates in the hepatocytes. This stage, the disease can be reversed. It's the reversible phase. If this person stops taking alcohol at this point, it can be reversed. But if the person continues, then it will progress. And there will be, with continual abuse, the inflammatory cells will infiltrate the liver very much, and then that will cause loss of functional liver tissues. There will be formation of scar tissue. The liver will become nodular, like a nodule, and it will shrink in size. So this is the problem associated with this whole thing. Let's still take it. I hope I'm not too fast. So with alcohol cirrhosis, we said is the most prevalent type, and it happens due to excessive intake of alcohol. This can be complicated with malnutrition. You know, sometimes these alcoholics clients, they don't really like eating. So it excess alcoholic intake with or without malnutrition directly related to the toxic effects of this alcohol on the liver. So we go to the biliary cirrhosis. We've talked about it, and we say that it is caused by obstruction of bile due to a calculi, and then the bile ducts begin to, necrose. There will be necrosis and fibrosis too, leading to that backflow of of bile to the liver. We also talked about the post-necrotic cirrhosis. We said the post-necrotic cirrhosis results from a chronic severe liver disease such as hepatitis, which is also caused by inherited metabolic liver disorders such as Wilson's disease. So Wilson's disease can also cause this post-necrotic hepatitis. But irrespective of the cause, we also said that drugs, chemicals, and all those things can cause this post-necrotic liver cirrhosis. So irrespective of the cause, we just know that there is a chronic progression of destruction, repeated assault, repeated injury to these hepatocytes, to these liver cells, that will now result in forming of a fibrous, scarred liver. So the early signs are quite vague and non-specific, but the patient may be complaining of fatigue, significant change in their weight. They may have GI symptoms, anorexia, vomiting, and abdominal pain. The liver, if you palpate it, it will be tender. I lost some audio clips, so I'll just talk about liver biopsy before I go to complication. So for biopsy, we need to get informed consent, put the patient NPO 4 to 6 hours before the procedure, get baseline data, check the prothrombin time and platelet count, give vitamin K as prescribed, let them empty their bladder before the procedure, and place them in supine position with their head turned to the left and their right arm over their head. They should hold their breath after expiration. That is when they breathe out, to keep the diaphragm and the liver high in the abdominal cavity during insertion of the needle. So they obtain the tissue, and the procedure is just 10 to 15 seconds, so they can actually hold their breath. So the manifestations and complications we see in patients that have this liver cirrhosis is due to the impaired liver function. The liver cannot do what it's supposed to do because of this damage to its hepatocytes. Another complication and signs we are going to be seeing is due to an alteration in the blood flow through the portal venous system. So when the portal venous system has alteration in blood flowing through it, we are going to see different signs and symptoms. So early on in the disease process, when you touch it, the liver is going to be large. On palpation, is going to be tender. The patient will be telling you, oh, I feel pain. When you palpate it, then there is a characteristic right upper quadrant pain, because that's the location we are palpating. This right upper quadrant pain is because when you palpate the liver, it is enlarged. All the inflammations going there is what is causing pain. Now, other early signs we have talked about are the weight loss, weakness, and anorexia. Then the bowel function too will also be disrupted as the liver progresses, and this whole thing can result in liver failure, and portal hypertension will develop. So what happens in portal hypertension is that there is elevated blood pressure in the portal venous system of the gut. Blood now starts to be, the blood pressure in the portal system is too high, so blood now it tries to shunt itself, it tries to reroute itself from the portal vessels, from the vessels in the liver to the lower pressure vessels. So blood is shunted I take that again. Blood is shunted from vessels of the portal system into lower pressure vessels, causing congestion in the esophagus, in the rectum, where we now see them having hemorrhoids, as well as in the abdomen. It can affect different areas. And that is a big problem. It's a big problem. We also have ascites. So ascites will happen due to accumulation of serous fluid in the peritoneal cavity. And what will cause this ascites is because of the portal hypertension. Because in this portal hypertension, there is there's too much pressure in the portal venous system, which would cause an increase in capillary permeability. As the capillaries in the portal veins become more permeable, and then also alongside the high pressure within the hepatic vessels, there will now be a leakage. Okay? There will be a leakage of fluid into this peritoneal cavity. That is why we have ascites. And you know that the normal function of the liver too, which includes production of plasma proteins like albumins, like the albumin, it will not be able to carry out this function because it is damaged, it is injured. What will now happen? There will be reduction in oncotic pressure, because this albumin helps in maintaining the oncotic pressure in the vascular space, in the blood vessels. But now the liver cannot produce albumin. We now have this hypoalbumin, low levels of albumin. And then the fluid will begin to seep and escape out of the blood vessels, causing this ascites as well as peripheral edema. So these are our signs. Please note it down. We've talked about the portal hypertension, ascites, peripheral edema. There will also be fluid and electrolyte imbalance. You understand? Because of these fluid shifts. Then we have splenomegaly. Which is the enlargement of the spleen. Now, this will happen as blood is being shunted from the portal system into the splenic vein. So when the blood leaves the portal, is escaping from the portal venous system, it diverts some to the spleen, to the vessels in the spleen. And what will happen? The spleen too will start getting high volume of blood, which is not what it is used to. And what will those blood do? It will result in pooling of that blood, and we have an enlarged spleen. The spleen too will not be able to function adequately. We begin to see signs of anemia, low platelets, and WBC counts. Then this low platelets, the thrombocytopenia, we know that the normal range of platelet is supposed to be 150,000 to 400,000. When we have thrombocytopenia, we know that it's less than 150,000. So low platelets, this thrombocytopenia, as well as the decrease in clotting factor production by the liver, because the liver cannot produce its clotting factors. What will happen? There will be increased risk of bleeding in these patients. And then also low levels of WBC, leukopenia. Our WBC level is supposed to be 4,000 to 11,000. Different books have different range. Some will say 5,000 to 10,000. So Nclex will give us the reference to use, but just have an idea of what the value is and then the implication. Once we have leukopenia, the patient is at risk for infection. Then we also have another complication of esophageal varices. Now what happens here is that there's enlargement of these veins in the esophagus. They're enlarged, fragile, and over-distended veins in the distal portion, the lower part of the esophagus. And this happens from portal venous congestion, because we said that there will be blood shunted, so it will be shunted also to the esophageal veins. And when it gets there, we begin to see this distension, over distension of these what is it called? Excuse me. Over distension of this esophageal vein. It will now dilate. There will be an outpouching. It will form a pocket. Then you begin to see varices. And we know that the clients with esophageal varices, they are at risk, high risk for bleeding. And matching this patient already has thrombocytopenia. So you see what is going on. So these are the patients we use this our Blakemore tube for. You know, the Blakemore tube kind of acts like a tamponade. You know, when it's used as a tamponade, sort of to prevent rupture of these vessels, of these varices. Then another thing is high roughage foods, like taking bacon or foods that have high roughage. They can lead to bleeding of these fragile varices as the food is passing through the esophagus, and then you know the vessels is near the esophagus. So I take it again. I said high roughage foods like bacon can lead to bleeding of these fragile vessels in the esophagus. We also have upper GI bleeding, which is another complication of liver cirrhosis. This bleeding may be massive due to, you know, if the esophageal varices ruptures, we have a massive bleed. Or if the patient starts having gastritis or peptic ulcer too, they can be bleeding. So we need to monitor for occult blood. We need to check for melena, blood stains, stools, and all that. As the liver is progressively destroyed, its ability to metabolize protein is also impaired. So ammonia and toxic waste starts to accumulate in the blood. There will be buildup of this ammonia, which comes from the protein. So now ammonia would affect the central nervous system. We know that is what leads to this hepatic encephalopathy that is characterized by the patient having altered level of consciousness, having problem with cognition and motor function. Then there's another important thing that happens: asterixis. Okay. Now, asterixis is also called the liver flap. Is an early sign of hepatic encephalopathy. Please, let's take note of it. You can jot this down. In asterixis, there is a muscle tremor that causes involuntary jerking movements of the hand and the fingers. So the patient is finding it difficult to keep the excuse me, please, to keep the fingers still. So that one is asterixis. Then we have the hepatorenal syndrome, where there's renal failure. The kidney begins to fail. Renal failure associated with end-stage liver disease. The cause is also unknown too, but it happens. So we have talked a lot, and excuse me, we can recap what we've said. You can try to see if what you can recall from what we've said. But let me just go over it again so that we get it and we know that we have learned something today. We said that liver cirrhosis is an end stage, it's like the end stage of many chronic liver diseases that is characterized by diffuse hepatic fibrosis, and then the normal tissues of the livers will be replaced with regenerative nodules, fibrotic tissues, which now cause a change in the structure of the liver, and then there's now an altered flow of blood. Blood cannot flow within the liver for it to do its function. So we can have elevated bilirubin levels. The patient can come down with jaundice due to this derangement in liver cells. And then the liver too will have decreased or inability to conjugate bile, and it cannot conjugate bile because its hepatocytes are damaged and it cannot excrete bile. So we have the jaundice. So we also remember that most of the clotting factors are produced in the liver, and because this liver is traumatized, it is damaged, it cannot produce its clotting factors. We know our clotting factors will be affected. The vitamin K will be affected because all these our fat soluble vitamins, or you can call it vitamins, I don't know, vitamins or vitamins. Fat soluble vitamins will be affected. So what will happen is that vitamin K, the ADEK, the vitamin A, D, E, K, all those ones will be affected. Clotting factors 2, clotting factors 7, clotting factors 9 and 10, they'll be affected. So because of this, coagulation studies, such as the prothrombin, the INR, the international normalized ratios, and the activated partial thromboplastin time will be high in these patients. It will be very high. So let's continue learning. We also remember we talked about albumin, that due to the liver cannot carry out its normal function, there will be reduction in production of albumin, so the oncotic pressure would reduce. Then when the oncotic pressure is decreased, it will promote leakage of these fluids out of the vascular space into the interstitial space, which will now lead to this edema, ascites, peripheral edema. Then the kidney will now perceive this low perfusion, then try to conserve sodium because the oncotic pressure has dropped. It's thinking that, okay, there's hypovolemia. So what happens? The kidney will try to activate its renin-angiotensin aldosterone mechanism to see if aldosterone can help it conserve sodium and water. When this large amount of water in the body continues to be retained, we now have what we call dilutional hyponatremia. So low levels of sodium due to increase in water reabsorptions by the kidney. So the patient with cirrhosis may begin to experience pruritus, where we have itching due to buildup of bile salts beneath the skin. There is itching. They have this pruritus. The bile salts, we talked about how the common bile duct allows for when there's obstruction in the common bile duct due to a gallstone, there will be backflow of bile juice into the liver. All those damages that the bile will cause will result to a buildup of this salt beneath the skin of our clients, and then you see them itching. So they are at risk of skin breakdown. Okay, they are at risk for skin breakdown. Then they also remember they have this edema, so there will be increase in skin fragile. The skin will be more fragile, so wounds I'm sorry, wound will not heal very well. Okay, poor wound healing will occur. There will be loss of muscle. There will be loss of because there'll be loss of muscle and fat tissue from the pressure points, such as the heel, the sacrum, and then the patient comes down with pressure injury. So what we can do for this is they can do the baking soda baths, apply calamine lotion to the skin, use cool wet clothes which can cool and soothe the irritated skin. Then the nurse will encourage the client to cut their nails short. They need to cut their nails short and then wear gloves. You cut your nails, you wear hand glove or a mitten so that they don't scratch their skin and cause more skin breakdown. You wear long sleeve and wear cotton, soft clothes. Don't go and wear nylon or something that will irritate your skin. We have cholestyramine. This one may be prescribed, is a drug that may be prescribed to increase the excretion of bile salt in feces. So we have entered medications now. So we are talking about the medical management, where we do cholestyramine, which will help to increase the excretion of bile salt in the feces, thereby reducing itching, the pruritus. So it comes it is packaged in a powder form, and this drug that comes in a sachet or a powder form, we have to mix it with food. So apple sauce can be used, apple juice can be used, and it should be given 1 hour after medication. 1 hour after taking any other medication this patient with cirrhosis is taking, so that we don't have drug interaction. This is an Nclex tip. Then I'll digress a little bit. Temperatures now, still on the skin issue. Temperatures such as going to have hot baths, showers may intensify pruritus. So we can instruct the clients to use room temperature water until the itching has subsided. So you don't go and use hot water, which will cause the itching to be worse. So in a patient with this cirrhosis and ascites, discomfort is often due to the pressure in the pressure of that buildup of fluid on the organs within the abdominal region. So when there is that ascites, the ascites is there's buildup of fluid in the peritoneal space in the abdominal region. That fluid there will begin to compress the organs there, affect the diaphragm, and our patients will have shortness of breath. There will be poor lung expansion. So what do we want to do? We want to position this patient in the fowler or semi-fowler position to promote comfort and reduce this pressure. So we know our semi-fowler position is 30 to 45 degrees. Then fowler position we know is 45 to 60 degrees. Now we also have the side lying position with the head elevated. That position also promotes comfort. So the enlarged abdomen, the stomach is big, will now rest on the bed, and then there will be decrease in pressure in the internal organs, so the patient can feel comfortable. So we should do good skin care, because the skin is prone to having pressure injury. So put them in that specialty mattress, turn them every 2 hours. This is our Nclex tip. Turn the patient every 2 hours. Distraction, using distraction technique to take the client's mind out of the problem, so they don't even enter depression, they don't start thinking about their condition, so they can watch TV, play video games, do their hobbies. They should also limit their sodium intake. There's sodium intake limitation. So, and Trendelenburg position is contraindicated in patients with ascites. Let's take note of it, because it will worsen this and breathing difficulty that the patients come down with. I don't want this video to be long, but we need to know what we need to know. So for the medications, we have substances that are toxic to the liver, such as alcohol, should be avoided. They are to avoid alcohol. Drugs that are broken down or metabolized by the liver. Hope I didn't say kidney. Please, if I said kidney, I meant liver. It's just a mistake. So drugs that are metabolized by the liver, including the barbiturates and sedatives, as well as hypnotics, are also avoided. Then we have doses of other drugs which may need to be adjusted. So if we have drugs, medications like all this phenobarbital, other hypnotics that are broken down by the liver, paracetamol, the acetaminophen, you can adjust the dose of these medications so that they don't put more workload on the liver that is already is struggling, it can't function well. We have several groups or classes of drugs commonly prescribed, such as the diuretics for the ascites. They also can take spironolactone, but we have to monitor the electrolytes level. Okay. Medications that are used to reduce ammonia. We said they have hepatic encephalopathy. So medications that are used to reduce ammonia absorption from the bowel includes this lactulose. So lactulose and neomycin. These are the two drugs that are used, lactulose and neomycin. Then we can also give them beta blockers like the propranolol and nadolol, that's Cogad, to reduce the portal hypertension. To reduce portal hypertension, the bleeding esophageal varix too, it will benefit from that if we reduce the pressure so that it doesn't rupture. We can also give them vitamin K to promote clotting. Platelets and other products, we have the cryoprecipitate like the fresh frozen plasma, or salt poor albumin can be given to these patients. Because of the GI symptoms, where we said they have GI bleeding and all that, we can give them antacid, proton pump inhibitors, and all those drugs. I want us to take note of something. Oxazepam, Oxazepam, is an anti-anxiety or sedative drugs that is not broken down by the liver, and it may be used to treat acute agitation. So this patient, because of the hepatic encephalopathy and the signs, the effect it have on the neurologic system, they may become agitated and angry. So we can give them this oxazepam, and it is is a sedative or anti-anxiety medication that doesn't need to be broken down by the liver. So that is it. We have already said the patient should stop taking alcohol. We can put the patient on sodium. The sodium restriction, sorry, I forgot to mention, is less than 2 grams per day. You take less than 2 grams every day to reduce edema. Also, the client can be on MPO. MPO, they may need total parenteral nutrition to support them. We can also give them vitamins and minerals as prescribed, such as the thiamine, the folate, that is the B vitamins, B12, as well as the fat-soluble vitamins, the A, the D, the E. We need to give them in water-soluble form. You know that they are fat soluble vitamins, right? But we know we have problem with fat metabolism, so we give these drugs in the water soluble form. All right, let's think about our nursing consideration, what we need to do. This is our Nclex focus. Let's look at our Nclex focus. We say we need to check their vital signs, the pulse, monitor them for us. We do the orthostatic blood pressure measurements. We know how to do the orthostatic blood pressure measurement, where we take the blood pressure when the patient is lying down, then we wait, and then they will sit up, then we wait again, then they will stand, and we check. And if there is any significant drop in blood pressure by 10 to 20 millimeters of mercury, or an increase in pulse rate above 10 beats per minute, then we know that the patient has orthostatic hypotension. We're still studying. I hope we are there. We are jotting. Okay, so you take the temperature, you measure their weight. We want to check the abdominal girth. Remember, this patient, they have ascites. There's reduced ability to break down the CHOs, so that will lead to hypoglycemia and reduction in energy. That is why they are fatigued. There's altered gluconeogenesis, altered glucogenesis, and glucogenolysis. The breaking down of glucose, synthesis of glucose, and making new ones is altered. So we need to watch out for hypoglycemia. So altered fat breakdown causes increased synthesis of fatty acid and triglycerides, which will lead to fatty liver and hepatomegaly. That's an Nclex tip. We said there's altered breakdown of fats causes increased synthesis of fatty acids and triglycerides, which leads to fatty liver and hepatomegaly. So we have altered protein breakdown, and we have said that this one is what causes all those albumin and everything. There's also decreased metabolism of sex hormones, such as the estrogen, the progesterone, testosterone. Now, this would lead to gynecomastia. Then they begin to have this loss of hair. They develop palmar erythema, the redness of the hands, all because of this sex hormone, that the metabolism, the breakdown of sex hormone is reduced. So we see them having this buildup of sex hormone, which will cause the gynecomastia, which will make the hair follicles begin to lose hair follicles. They have red palms, they have spider angioma, as well as erectile dysfunction and menstrual disorders. When aldosterone, there's a decrease in the breakdown of aldosterone. They have this renal syndrome too. When there's a decrease in the breakdown of aldosterone, we know that it will result in sodium and water retention, as well as worsening of edema and ascites. So this is it. They are fatigued, they are tired, they have anemia. There is clay-colored stools. That obstruction of bile flow leads to hyperbilirubinemia and jaundice. We have already talked about it. So that one too can also affect the stool colors, where we see them having the clay-colored stools, as well as the dark urine. Some call it the dark orange frothy foamy urine. Then that's a hepatomegaly, the splenomegaly, which we talked about, which happens due to pooling of blood, shunting of blood from the portal system to the to the spleen, that one leads to pancytopenia. So I think we have been able to analyze, we have been able to read through this procedure, this disease condition. Please, another Nclex tip you can see is that these patients, they develop what is called caput medusae. So caput medusae is an appearance of distended and engorged superficial epigastric veins. That is superficial veins in the epigastric region, that as you are looking at the person, you can see it. So you see these veins, they are radiating from the umbilical region and spreading across the abdomen. So sometimes they call it palm tree sign. Okay, it's sometimes called palm tree sign, and it is a sign of portal hypertension. So you see this, it is like a network of painless swollen veins around the belly button. It's not a disease, but it's a sign of this portal hypertension associated with liver cirrhosis. I hope this helps us. I'll continue this video in he has hiccup. Please give him water to drink. Okay. So I'll see you in the next video.